Before I start my lecture, let me thank the organizing committee for the invitation to speak in the 2021 ITPA. Now, my topic is tuberculosis requirements for panel physicians. I have nothing to disclose in relation to this presentation. Now, I'll be discussing country radiology requirements overview for US, Canada, Australia, and New Zealand. Country-specific requirements for latent TB infection for US, Canada, Australia, and New Zealand, as well as the technical aspects of film. So the primary requirement of panel sites is digital radiography. And this technique uses X-ray sensitive plates to capture data during examination, which is immediately transferred to a computer without the use of intermediate cassette. So it's basically, it removes the requirement of darkroom procedure. So what are the advantages of digital radiography? You have reduced time, which we are able to view images within 10 seconds, which is really advantageous in heavy X-ray workloads, such as in our setup. You have reduced radiation and better image quality because of the much lower failed exposures, ability to take more than one exposure without repositioning the sensor, storage and maintenance of the images, electronic transmission of images, which is very important, meaning that images are obtained in our clinic that can be electronically distributed using the internet through e-medical. Now for monitors, these are part of the equipment of digital radiography and should be medical grade monitors, which means that there should at least be 3 megapixel display resolution. For additional views, such as the apicolordotic and lateral views, they are requested to further assess suspicious densities or opacities in hidden areas of your chest radiograph. Now, this is the Canada chest X-ray report form that we use, and listed are the abnormal lung findings and their corresponding grade. So we interpret the chest X-ray and mark the box based on the radiologic findings. Now a grade of 4 and above, up to 4.7 warrants sputum examination. Now here is a chest X-ray of an applicant showing cavitary lesion in the left upper lobe, as shown here. So we tick or mark the box with a grade of 4.7 here. So patient is for sputum examination. Another chest radiograph of a different applicant here showing a single linear density in the left lower lobe, as shown. This corresponds to a grade of 1.1. Sputum is not warranted in this case. Now for latent TB infection screening tests, chest radiographs are taken for applicants less than 11 years old. Chest X-ray AP and lateral views are done, while for applicants 11 years old and older, a chest X-ray PA view is taken. Now, this is a US tuberculosis worksheet. Now, the group of abnormal chest findings at the left side corresponds to a class A, suggestive of TB, and warrants sputum examination. Let me show you a chest X-ray of an applicant showing bilateral upper lobe infiltrates, cavitations, discrete nodules, and associated volume loss. So we mark the abnormal chest findings, like the infiltrates, the cavitary lesions, the discrete nodules, and the associated volume loss. So we mark the abnormal lung findings under class A. Now, for latent TB infection screening, child applicants less than 10 years old who receive a chest X-ray should have a standard AP or PA view as well as a lateral view. For applicants 10 years old and above who receive a chest X-ray, a standard PA view is done. Now, here is the chest X-ray worksheet for Australia. And based on the X-ray findings, the appropriate box is marked in the worksheet, and in eMedical, a grading system of A and B is selected. Now, a grade A shows no significant findings, while a grade B would show an abnormal chest radiograph. Now, I like to list the abnormal chest findings which are consistent with active disease. As shown here, we have cavitary lesions, pleural effusion, apical fibronodular fibrocalcific lesions, single multiple pulmonary nodules which are non-calcified or poorly defined, isolated or multiple hilar or mediastinal masses, lymphadenopathy, pulmonary nodules, masses greater than or equal to 1 centimeter, non-calcified pleural fibrosis and or effusion, interstitial fibrosis, parenchymal lung disease, acute pulmonary disease, and notable apical pleural thickening, which exhibit rough or ragged inferior border. Now, for abnormal findings occasionally associated with TB disease, we have the following. We have the solitary granuloma, less than 1 cm with an unremarkable hilum, solitary granuloma less than 1 cm showing calcified and large lymph nodes, single, multiple calcified pulmonary nodules with distinct borders, calcified pleural lesions, and claustrophenic angle blunting. Now, in the presence of all these abnormal chest findings, they are assigned a B grading in the 502 examination. Now, these chest X-ray findings enumerated, like your single solitary calcified nodule, your bone island, your single fibrotic streak band or scar, minimal claustrophenic angle blunting, aortic calcification, apical capping with smooth border, atelectasis, zygous fissure, breast implants, cardiomegaly with cardiothoracic ratio of less than 60, dextrocardia situs inversus, nipple shadows, pectus excavatum, raised hemidiaphragm, rib abnormalities, and scoliosis. These findings are assigned an A grade, meaning they are not considered significant. So they are assigned an A grade in the 502 examination and should be noted in the general supporting comment field. Now, here is a chest X-ray of an applicant showing hazy infiltrates with cavitations in the left upper lobe. So we report our findings in the worksheet and in eMedical. In this case, okay, we mark it as abnormal lung fields. And for strong suspicion of active TB, we mark it as yes. So in this case, grade B is assigned. So the panel radiologist on duty signs the declaration and submits the case in eMedical. Now, for pediatric screening of latent TB infection for Australia, requires the following as listed. Now, with regards to the chest X-ray, applicants 10 years old and below would need an AP or PA and lateral views, and applicants 11 years old and above would need a PA view done. For New Zealand, the chest X-ray findings, these are graded also A or B. Chest X-ray findings that are highly suggestive of TB, such as your extensive infiltrates and your cavitary lesions, these are marked yes in the worksheet and in eMedical. So in this chest X-ray of an applicant showing extensive infiltrates in the left lung with associated atelectasis or volume loss. So we mark it as abnormal lung fields, and we mark yes for strong suspicion of active TB. So this is B graded. Now, let me discuss the technical aspects of film. For extent, we have the entire lung fields from the apices to the claustrophenic angles should be clearly demonstrated. For penetration of exposure, the first 4 vertebral bodies and ribs are visible. The rest of the vertebra should be visible through the heart shadow. For positioning, the spinous process is centered between the clavicular heads on the AP view. Inspiratory effort, there should be visualization of the 10 posterior ribs above the diaphragm is a good indication of good inspiratory effort in adults. In children, 5 to 6 and the 5 to 6 anterior ribs or 8 to 10 posterior ribs above the diaphragm is a sign of good inspiratory effort. Now, absence of motion would show well-demarcated or well-marginated vessels, cardiac margins, and diaphragms. Now, for the others, there should be absence of objects or artifacts on the applicant's clothing, which may obscure underlying lung opacities. Now, I think that's my last slide, and I would like to thank the organizing committee again for inviting me and being a part of this convention. Thank you.
Hello, good afternoon. I am Dr. Orlando Duarte, radiologist from Consultorio Divisa in Dominican Republic. I'm going to be speaking for a few minutes about the screening requirement for United Kingdom. First, we have the pre-departure TB screening program for all of those UK applicants who intend to stay in UK for over 6 months and are traveling from a country listed by the World Health Organization as a country with high TB incidence. Those applicants will be screened by a physician appointed for the UK authorities, and that will include taking a digital direct chest X-ray. The purpose of the screening is to detect suspected presence of active pulmonary TB. There are general arrangements in the UK TBTI that should be implemented. The applicant has to carry a valid passport. The applicant schedule an appointment with the appointed physician to take the screening process. All family members should be screened together and if possible, in the same day. Applicants are going to be briefed about the screening, and they have to complete a consent form and sign it. Children under 11 years old must be accompanied by a parent or a tutor. The direct digital chest X-ray is the preferred screening tool for active TB diagnosed. Positive finding on chest X-ray of active or old pulmonary TB will need 3 sputum examinations to get results. Now I am going to be speaking for a few minutes about the digital radiography system. The direct digital X-ray system allows the panel site to obtain easier and faster good quality chest X-ray. The transition to digital imaging is in some countries already done. Digital direct chest X-ray is the mainstay of imaging to screening pulmonary TB disease. Most developed countries require direct digital chest X-ray and high-definition monitors for pulmonary TB diagnosis. DICOM is a digital imaging and communication in medicine, and the standard was developed by the American College of Radiology and the National Electrical Manufacturers Association to process all the medical X-ray images. DICOM consists of services, most of which involve protocols and mechanisms to manage and transfer medical data. The combination of patient data and X-ray image in the sensor and the management of the data to be printed interpreted, stored, queried, or transmitted to remote locations. The last one of the lecture will be about fraud prevention methods. The panel physician signs agreement with the proper authorities and are responsible of all the screening process, including the prevention of fraud. They had to ensure that the medical screening result correspond to the proper applicant. Typical risks of fraud are the substitution with another person, or to bribe the inside or outside screening staff to get normal results. From the original X-ray equipment through the console, the applicant's personal data can be corrected if it is an error or altered in a fraudulent way. This is an example of altered personal data incorporated in a normal digital X-ray to do a fraud. There are some kits for fraud prevention, and the main one is to keep the chain of custody in all the screening process. You have to be aware of possible substitution, and your staff or yourself should do a full passport verification and compare the signature and picture you taken with the passport picture and signature. CCTV cameras should be located in key areas. If you need an internal document, you can do whatever to aid in the screening process. You should have trustworthy staff in all the steps of the screening process. Outside collaborating offices should be scrutinized as a reliable source of studies. These are some pictures of our panel site that shows the admission clerk, the medical staff, and the cashiers, where the verification of documents and procedure help in the screening process and in the prevention of fraud. This other picture are the book of signature in the X-ray department and the verification of the passport before taking the X-ray to the proper applicant. In the middle, we have a document that helps us in the internal process and to prevent the risk of fraud. Thank you very, very much for listening.
Thank you for the opportunity to speak about TB disease and latent infection today. I have no conflicts of interest to report. And today we are going to be first discussing the common findings of active TB in adults and children, and then I will briefly discuss latent TB infection, what it is, and why I think it's important. Well, TB can present like many other disease conditions. The chest X-ray provides important clues that can prompt TB laboratory testing. Shown here are some of the most common types of findings on chest X-ray that you're familiar with for persons with confirmed TB. The frequency of each of these abnormalities is different for adults and children. Let's first turn to adults. Adults with active TB most often present with an infiltrate like this one. TB consolidations may be patchy or poorly defined or even dense. In contrast to other causes of infiltrates or consolidation on chest x-ray, such as pneumococcal pneumonia, TB tends to be more chronic or indolent, and the location is frequently in the apices and posterior segments of the lungs. In addition, cavitation may be seen within areas of dense consolidation. Here's an example of a patient with extensive pulmonary disease. Cavities may be multiple, like in this film, and result from necrosis of the lung. These cavities have a high concentration of mycobacteria, and the lobes are thought to be in the upper regions of the lungs, are thought to be a site for TB proliferation because there's decreased lymphatic flow in those areas. Although cavitation is considered a hallmark of TB, it really occurs in less than 50% of persons, adults with confirmed TB. One great aspect of your work as a panel physician is that when you detect active TB, like in this person with very extensive disease, even in those with advanced disease, TB is curable. And the film on the right shows the patient following treatment. So you just see a small linear scar-like abnormality remaining. So by detecting TB in the screening program, you're really offering something of important value to your patient, the chance to be cured from a disease that is life-threatening and infectious. Now, here's an example of a patient that has TB that is very recently acquired. So in adults, when TB occurs soon after infection, we sometimes call that primary TB. You may see adenopathy in the early phases of disease, but this is very much less common than in children. It is more often found in those with HIV, for example. This picture demonstrates not only adenitis, but consolidation that occurs nearby. Now, a pleural effusion may be another manifestation of TB. Effusions are much more common in adults with primary TB than in children, but you can also see this in older and immunocompromised patients, as in this case. You'll note blunting at the costophrenic angle with a decubitus film, you're helping to confirm that fluid is present. So fluid in the pleural space, normally the pleural space is lubricated by 1 to 5 cc's of fluid. You can see blunting at the costophrenic angle laterally on the PA film when at least 250 to 300 cc's of fluid is present. With a lateral film, you can visualize blunting from just 75 cc's of fluid. And then the lateral decubitus film, you can see as little as 10 to 25 cc's. So these additional X-ray views are super valuable to help you spot a pleural effusion that may be due to TB. Again, here we are visualizing the utility of decubitus films, and this chest X-ray illustrates how a subtle finding on a PA film can be illuminated on a decubitus film, showing significant free-flowing fluid in the pleural space. What about nodules? Tuberculosis may present with a nodule that seems tempting to dismiss or ascribe to other causes. However, even small nodules like this one may indicate active TB and multiplying bacteria. The features of the typical TB nodule or tuberculoma to look out for are that TB nodules are often solitary, non-calcified, in an apical location, and well circumscribed. While there are numerous causes of nodule, TB is an important one, and a nodule seen on screening exam should prompt further diagnostic steps, including TB specimen collection. So you can see these multiple causes of nodules, but again, we need to think TB when we see a nodule in the panel site setting. Now, sometimes nodules are seen, like in this patient who presented with a cough, that are very tiny and numerous and scattered across the lungs. Miliary TB should come to mind when you see this kind of film. Nodules in miliary TB are diffusely distributed. They're about 2 to 3 millimeters in size, so very tiny, and they have a slight lower lobe predominance, indicating hematogenous spread of the mycobacteria. So is this TB or not? In the active screening program at panel sites where patients are less frequently presenting with symptoms and extensive illness, your detection of active TB sometimes requires, a very careful look at the x-ray. In this 39-year-old woman without symptoms, her chest x-ray on first blush appears normal. But you can spot a linear density that is scar-like that months later, over to the right, became more obvious. The linear density is an abnormality that can suggest active TB and is an indication for specimen collection. So you can see, from this progression that the small stuff does matter. So you need to keep your eyes open for the more subtle findings. So I'd like to summarize for a moment about the chest x-ray presentation of TB in adults. Here are some key points. First, there are a range of typical chest x-ray findings from infiltrate and cavity to nodules, fibrotic scarring, and effusions. But chest x-ray findings may be quite subtle with active TB, especially when persons are asymptomatic, presenting for screening at panel sites. They may, for example, have smoldering chronic active TB from recently acquired TB infection or inadequately treated disease. In older or immunocompromised adults, findings may be atypical and include lower lobe disease or lymphadenopathy. The main take-home point is that if in doubt, collect sputum and exclude active TB disease. Now turning to the very young applicant. This is a 6-year-old who was exposed to a family member with smear-positive TB. The child was asymptomatic, but had a new positive interferon gamma release assay result. You can see the left infiltrate on chest x-ray. In children, the lateral view helps you quite a bit to spot an abnormality and to prompt specimen collection and treatment. Another youngster who is 10 years old presents here with asthma and is a contact to pulmonary TB. He developed cough and was initially treated with antibiotics. The quantiferin 10 weeks later was found to be positive during screening. You can see the hilar adenopathy on his chest x-ray, a common finding with TB in children, in contrast to adults. This is a young adoptee who has even more prominent hilar adenopathy and consolidation. It's rewarding to be able to detect TB in the very young and get it treated before tragic consequences occur like disseminated TB and meningitis. So in summary, children, in contrast to adults, may present with a small area of infiltrate in the lower or upper lobe, adenopathy alone, or both. The lateral film, in addition to the PA, is especially important in detecting TB in young children. Now, this last film is a normal one. Most of your applicants will have a normal chest x-ray. The question is whether they are infected with TB bacteria. I want to spend the next few minutes discussing latent TB infection, what it is and why it is important. TB disease can be treated. So why is latent TB and prevention of TB important? Even though TB disease is curable, 1 in 10 do not survive treatment. Half are hospitalized, and that is disruptive and costly to the person and their family. After treatment, there may be a shorter lifespan, and children can have tragic consequences. The cost, in addition to the human toll, is expensive. In California, where I work, over $200 million per year is spent on TB costs. Because most TB disease results from progression from latent infection, often after a number of years, these consequences and costs that I just mentioned can be averted by identifying and treating infection at its earliest stage. So let's look at the natural history of TB illustrated here for a moment. Upon exposure to TB bacteria, some are able to avoid infection altogether, so they are in the non-affected group. Among those who do become infected, a small number go on to rapidly, in a matter of weeks to months, develop active disease. You see in the lower part of the slide. However, the majority who are infected, and note that there are 1 in 4 persons worldwide that have latent TB infection, they tend to control this infection for a period, and often a long period and sometimes for life. So this infection is quiescent or smolders until years later when some may progress to active TB disease. So the opportunity that we have is that once infected, we can arrest future disease progression by treating TB infection in this early phase of latent TB infection. Now, this is not a new concept, but we're understanding that this is really an important place that we need to go worldwide in order to get ahead of the TB disease curve. So let's look at this a different way. Here's the spectrum of TB disease. We know that it's really actually not separate stages, but a continuum. And latent TB infection, just to be super clear, is defined by the absence of TB symptoms and illness. The presence of a positive IGRA or tuberculin skin test and a normal chest x-ray. In latent TB infection, the patient is not infectious, can't spread TB. However, active TB, as we've seen in the radiology review, can start as a subtle, insidious illness as bacteria multiply and cause pathology. Active TB is usually marked by a positive culture and an abnormal chest x-ray. So this evolution from latent to active TB can take months, but more often it takes years. Again, a good thing where we might get the upper hand from this pathogen by offering treatment to those who are infected. What's made this opportunity even more exciting recently is that we can tackle latent TB infection in a much easier fashion than we have been able to in the past. We now have access to better diagnostic tests like the interferon gamma release assay and much shorter rifamycin-based treatment courses, which you'll hear more about after I conclude. Note that the WHO is now focusing more and more on scaling up latent TB infection treatment as a really critical step to drive down global TB incidence. So this topic is one to look towards and master. There are challenges to addressing latent TB infection, however. The patient feels well. They may not perceive a risk or urgency. They may be worried about medication side effects and may be concerned about treatment costs. In addition, the provider may not have experience or knowledge about latent TB infection testing and treatment and have many competing priorities. Well, active TB disease detection is the main critical role for the panel physician. The panel physician can become more familiar with latent TB infection, its detection, treatment, and in that way can communicate the importance to the patient. So when that patient is offered treatment in their future, they can understand the value. So you can really make a difference both in detecting active TB when it exists, but also can help plant the seed and communicate support for treatment of this earliest stage of TB infection, latent TB infection, when treatment is offered, perhaps in their destination country. So thank you very much for your time. I'll end here. Good morning. Now I'm going to continue on to a new subject that concerns us all. In the past year and a half, we faced something that we never thought was possible, a pandemic that has turned our lives upside down. However, those of us in TB are facing diagnostic dilemmas. We know in TB that everything that presents with a cough, a fever, an infiltrate is not COVID. But often in the community, it's really hard for people to think about any other disease other than COVID. So I'm going to talk now about COVID and TB and the intersection of those two diseases. I'm showing here on this first slide 3 different cases that we've seen in California, among many, where TB diagnosis was not on the physician's mind. Instead, persons that had tuberculosis were diagnosed with COVID or went through a diagnostic workup and had long delays in diagnosis. So I'm going to go through each one in sequence. The first case is a young woman born outside the US who was pregnant and hospitalized for cough. She had fever and shortness of breath. Her chest x-ray showed multiple nodules in the right and left lung fields. COVID-19 testing was performed multiple times and was negative. After 10 days, sputum was finally tested by AFB smear and nucleic acid amplification testing. Both showed, including culture, Mycobacterium tuberculosis. Ultimately, her diagnosis was miliary tuberculosis, and she was very sick and in the hospital for a long time, at a time when we really didn't like to have our tuberculosis patients hospitalized because of potential COVID exposure. So this was a case that could have been prevented in terms of lengthy hospitalization had she received a TB diagnosis earlier. Case 2, COVID-19 positive inpatient with a worsening clinical picture dies on hospital day 9. Sputum culture was obtained at death and was positive for M. tuberculosis. So this is a very unfortunate outcome that we'd like to avoid. And the clues during this patient's illness were 1, a history of weight loss, which is not typical for COVID. 2, this is a scenario in California, and the fact that she had a birthplace outside the US where TB was endemic should have been an important clue as well. And then finally, she had known contact, known exposure to TB if someone had pursued that history. However, although these clues were present, no TB testing was performed until clinical deterioration, so around the time of death, where she had very advanced disease. She had cultures obtained for tuberculosis that were only positive, unfortunately, after she died. So this is a scenario that we want to avoid. Case number 3, how COVID can impact TB detection. This was a patient who had cough for 4 weeks and weight loss. The patient with suspected TB was not admitted to save beds for COVID. In fact, she was discharged from the emergency room, and there was no sputum collected in the emergency room. She required COVID-19 test results prior to being able to get sputum induction. So about 10 days occurred after discharge from the ER before sputum induction was obtained. Finally, AFB smear culture and nucleic acid amplification testing was sent. And then it was multi-drug resistant TB that was detected 4 weeks after TB was first suspected. So she had plenty of time early on in her illness when she presented to have TB diagnosed. Instead, she waited at least 4 weeks for TB to be detected, and it was MDR TB, and there was a chance for transmission to her family members and community. So these are all situations that we're trying hard to avoid. And we also have questions raised with these scenarios about what is the interaction with TB and COVID. I showed you scenarios where TB diagnosis was delayed, but what about when someone has both TB and COVID? Does TB promote the worse consequences of COVID that we're seeing? Does it increase mortality, or does the opposite occur where COVID may increase latent TB activation? Here are 3 studies, actually 4 studies that have looked into these questions. You can see that a study done in 2020 that was published in CID showed that there was an increased hazard ratio for death when TB and COVID occurred. So for current TB, when someone had TB and COVID, you had a 2.7 ratio, almost double the likelihood of mortality. If you have previous TB and then developed COVID, you also had an increased risk for mortality. So this was an important study. It included over 22,000 persons. The next study I wanted to mention occurred in Europe with Tadolini and also published in 2020, showed that COVID TB mortality was 12.5%, much higher than COVID alone. We know that COVID mortality, though of course in the older age, is really high, but when you take all comers, it can be, around 2%. So you can see that COVID, when it comes with TB, can have a much higher mortality. This third study that was conducted in the Philippines with over 500 persons showed a risk ratio for death that was also increased. Again, more than doubling with current or prior TB. And the time to death in someone with COVID and TB was shorter. Finally, why is it? What is the biologic plausibility for this pathogen, namely TB, to alter the consequences of COVID? A mouse model experiment using marine coronavirus gives us some insight. You can see that coronavirus in this study shows some possible acceleration of activation of dormant TB through affecting our innate immunity pathways. So there are a lot of potential mechanisms, and there is very suggestive data from different sites across the world that TB infection can alter COVID, and co-infection can be much worse than the single infection alone. So we wanted to look at the interaction of TB and COVID in California. We wanted to explore the potential interactions that I've just mentioned. How does COVID-19 and TB affect similar populations? So we know that TB often affects the most vulnerable and those with comorbid conditions like diabetes, immunocompromised. We also know that COVID-19 does the same thing. And both, have a higher impact on the elderly. So we want to explore this intersection in terms of populations. We also wanted to look at severity and mortality. Is that increased with prior or current TB disease when we look at our California data? And then finally, does COVID-19 infection increase progression from latent TB infection to TB disease? And I think we'll know the answer about this last question as we get further along after the entry of COVID and the pandemic. So let's take a look at the cases that we've seen early in 2020 in California. These were cases or persons who had both TB disease and COVID. They may have not been simultaneous. TB may have preceded COVID, or COVID may have preceded TB. So if you look at this group of patients, there were 77, and you look at disease severity, you can see that 42% had COVID symptoms. So these are kind of the more classic COVID symptoms, not weight loss, et cetera, symptoms of TB. And we know that if we looked at just COVID, so many COVID patients are asymptomatic or have really mild illness. That is the majority of COVID. So this 42% is much higher. The fact that persons with COVID and TB were more symptomatic. How many patients had severe COVID? And although we know so much about the high mortality and about the disproportionate deaths in older, we also know that COVID for many people is mild. But if you look at this data of 77 persons who had both TB and COVID, you can see that a third were hospitalized during their COVID illness, and 10% were in the ICU. 3% had acute respiratory distress syndrome, all manifestations of very severe COVID. So then when we looked at our TB case reports, about a third had severe TB disease. So that meant bilateral disease on chest X-ray or cavitary smear positive disease as opposed to smear negative non-cavitary. So when we tried to look at this interaction, we saw that TB and COVID disproportionately affected minorities and those with comorbidities, and the intersection of these two diseases occurs at an older age. And I'll show you that data in a moment. We also saw that the elderly and those with comorbidities have a high frequency of adverse outcomes when these two diseases occur. And we do see data that both severity and mortality may be increased. To take this data in context and ask what is actionable if we can prevent TB disease and COVID, we now have vaccination and we have mechanisms to prevent TB disease, and we focus on the most vulnerable, we can help avert dual disease and this potential synergistic effect that the two pathogens can have together. We have outstanding questions, however, on what causes it and exactly how often it occurs. So I'm going to go ahead and now go a little deeper into what I've just summarized, the mortality and the populations. So when we look again at those 77 persons, we saw that 12% died. And if we look at those who had TB and COVID within 120 days of each other, 1/3 died. So that's a much higher mortality than the 2% that we see across the spectrum of COVID. Who were those persons with TB and COVID who died? What were their characteristics? Most were male. The median age, as expected, was older. In California, we have disproportionate populations that are affected include those who are Latinx, those with diabetes, and then again, severe TB disease occurred in 2/3. So the nutshell here is that those who had TB and COVID, particularly those who had it close together, had a much higher mortality and much higher likelihood of having severe disease when we look at our California cohort. Now, what about the global impact of COVID on TB? This Johns Hopkins University publication showed modeling effect of, now we're talking COVID, excuse me. Back to the slide on the model of global impact of COVID on TB. What are the impacts of having an extended period of isolation? The 3-month lockdown that occurred globally in many parts of the world showed that even after a 10-month recovery, modeling that we add 6.3 million TB cases in the next 5 years and 1.4 million deaths. And I wanted to mention this because this relates back to the first set of slides where you have a decrease in TB case detection. And you have it not only because providers aren't thinking TB, but you have it because people aren't presenting with TB symptoms. They're not going into healthcare delivery sites because they either are isolated or those delivery sites aren't open, or they're crowded with COVID, or they don't want to endanger themselves and put themselves at risk for COVID. So the impact that we're going to see, those of us who work in the TB world and are on the lookout for TB, is that we'll see many more cases of TB in the future. We're going to say after a drop in TB, we're going to see a surge. And so this modeling through the Stop TB partnership showed that COVID-19 might set us back at least 5 years in the global fight against TB. And you may be seeing that in the panel sites. So what are the efforts that can be leveraged for both diseases, that we know intersect? These both are life-threatening respiratory diseases that are infectious. We know that TB isn't going away. We have not ended TB globally. So in California and across the world, there is a continuity of government operations, those in public health, those that are working in settings where you're looking for TB and helping TB patients. We need to protect those critical capacities. We can't let those critical capacities shrink in the face of the pandemic. We also need to have very good surveillance with ongoing monitoring to detect worrisome signals. Are we seeing more people that are dead at diagnosis that did not have the chance to have curative treatment because TB wasn't diagnosed, they presented too late, or a provider didn't think TB? We're doing a lot of surveillance in California, looking to see, in a month-by-month basis, whether we're seeing more TB deaths and we're seeing more severe disease. We also have started to send out provider alerts to maintain vigilance about TB detection. That's really important because it's really easy to just think about one disease, that everything is COVID, when in fact people may have both, or they may in fact have TB, not COVID, like I showed you initially. I think many of us are using telemedicine to extend our services so we can reach the patient who might be in isolation but have TB symptoms. TB drug supply assurance is really critical. I think during COVID, during the pandemic, there were a lot of interruptions in supplies of many raw ingredients of many drugs. And so that we need to make sure that we have the right stockpile and the right drugs within our reach to give this life-saving treatment for those who need it. And then finally, there's been a lot of competition in terms of respiratory protection, isolation, housing, oxygen, and we need those supplies also for TB, which we can cure in most cases, but we need these typical ingredients of patient-centered care. And this is sometimes really hard in the midst of an emergency, in the midst of a pandemic. So these are some of the steps that we're trying to undertake and safeguard in order to have fewer people die from TB while the pandemic is occurring or even waning. So looking forward to kind of building a TB-free world while we're responding to the COVID-19 pandemic. This is an article that was published by UCSF, where I also work, really talking about how there's an opportunity, a positive opportunity for synergistic efforts. So we know that TB and COVID affect the same vulnerable populations and have a much higher severity and mortality in the older persons and those without health care. And so that what we want to do is not go into communities, do extensive outreach, and really address only a single disease. We've learned that lesson with HIV and TB, and we want to think TB while we're thinking COVID, and make sure that the resources that are starting to really emerge and innovations for COVID, while we're vaccinated for COVID, can we think about diagnosis for TB through symptom screening, through risk assessments, even preventing TB in California? So we have one great example in San Diego, California, where the program, while someone is waiting that 15 minutes after they're getting their vaccination, they're getting a TB risk assessment. They're being linked to care for latent TB infection treatment. What a great thing to give a person an opportunity to prevent a preventable disease in their future while they're getting a vaccination for another disease. So to summarize the messages in my discussion of the intersection of TB and COVID, communities at highest risk for TB and COVID certainly overlap. The host and pathogen interaction of COVID and TB may increase mortality for those that develop both disease or who are at risk for both. And that needs further investigation. We want to understand that interaction better. What about the impact of COVID-19 pandemic on TB control and prevention activities? We do expect to see an initial decrease in TB from lower detection, from more persons isolating and not mixing, and also in places that are low incidence, like the United States, from lower in-migration. But we will see that change. We'll see a rise in TB cases. You'll see a rise in TB cases in the panel sites, and you'll see a rise in low incidence areas as a consequence of earlier decrease in detection and some transmission. We will also see the effect of undetected latent TB infection over time. So contacts who are not evaluated during the pandemic will go on to develop TB, and we'll see that in panel sites in all countries across the world. And then the new opportunities that we have before us, the synergies that can advance elimination and TB progress. As the pandemic response continues, we really all need sustainable staffing plans, and the same innovations that are being used for COVID, we need those innovations for TB care and prevention to really safeguard these decades of progress that we've made with TB and our step towards ending TB. Our next steps in California are to identify the highest impact of synergistic efforts that we can take to prevent TB and COVID in vulnerable communities. And we also are involved in looking at our data in depth over time and further investigating TB and COVID disease interactions. So thank you very much. Today is always a great day to stop TB, and it's also a great day to stop COVID. Recommendation of WHO on coexisting TB and COVID that calls for bidirectional screening. And so this is an effort that is particularly important in high-burden countries, where when someone has COVID, you need to also think TB and vice versa. Thank you very much.
Hello, and welcome to my study in Perth, Western Australia. You will have heard from Dr. Flood about the importance of latent TB infection and diagnosing and treating it, and in fact, the increasing importance of that. And it's my job to now briefly describe the practicalities of the diagnosis and treatment of latent TB infection. I have no conflict of interest. In diagnosing latent TB infection, there are a few important steps before you do the test. The first is that you have excluded the possibility of active pathology. If a patient is unwell, you must make sure they don't have active TB. That's the primary purpose of a TB specialist, both in regard to symptoms, their radiology, or indeed any histology. And related to that, of course, is that the microbiology is by definition negative. If you have, we often see latent TB infection and active TB as separate conditions. They're actually a continuum biologically. But for practical purposes in clinical medicine, we need to exclude active TB as a negative culture and then diagnose the latent TB infection, which can only be diagnosed by measuring the immune response. And then like the culture is only for active TB, the diagnosis of the immune response is not a test for active TB and only ever a test for latent TB infection. And then finally, if we're going to do a test for latent TB infection, we should do it with the intent of offering the preventive therapy to the patient. And so you should start right from the beginning before doing the test, counselling the patient with a view to doing that test and ensuring that they understand that's the intent. And so we have two tests available to us for the diagnosis, broadly speaking. The first, and well known, I'm sure, to the audience, is the tuberculin skin test, or Mantoux skin test, where we take a mix of proteins from the tuberculous organism, in Australia the tuberculin, which is shown on the right, and inject it into the forearm of the patient and measure the immune response as an indurated reaction in the dermis of the skin 72 hours later. There's a number of pitfalls to this test, although it's served us well for 100 years. The first is that the patient has to return 72 hours later to get a reading, and those 2 visits can be inconvenient. The second is that it uses a non-specific mix of antigen, and so we see cross-reactions with BCG and with environmental marker bacteria, and that gives us false positive reactions. Thirdly, we don't have any indication that the patient may be allergic, and if the patient is allergic or has no immune response, they can have a false negative reaction. And then finally, and possibly most importantly, is it requires some skill, and it needs maintenance of that skill to give the intradermal injection and accurately read the result. And so more recently, we use interferon gamma release assays. And so these are the ones that you'll be used to, where you take a sample of blood and the immune reaction is measured in the laboratory by measuring the T-cell gamma interferon response to specific TB antigens exposed to the blood in the laboratory. And the 2 different tests that essentially do the same thing, there are some important differences in the laboratory procedure, but they give the same result, are the quantiferon TB Gold assay, which was actually invented in Western Australia, but is obviously a global product now, and the T-spot TB assay from Oxford in the UK. The advantages of these tests are the convenience of the blood test, and therefore that the patient really only needs to visit for a single visit, although I'd argue that they should come back for the second visit to get the result. Secondly, that they have improved specificity. This means there's less of the cross reactions because the antigen that's used to induce the immune response is much less, is very much more specific to the MTB organism. And then finally, the test has an inbuilt test for allergy. And so if the patient's immune response is poor, and in other words, they're allergic, it will come back as an indeterminate result, and you know that the test has failed rather than getting a false negative. And so for these various reasons, in most circumstances, the IGRA tests are the best for diagnosing TB nowadays. Finally, just to reiterate something I hinted at earlier, these tests are never a test for active TB. And then secondly, and even more importantly, I think, is that they do not predict future active TB. The interferon gamma release assays are no better than the skin test at doing this. And this is one of the downfalls of these tests generally. And so now I come to treating the latent TB infection. You've done one of these tests, let's say the IGRA, and had a positive result. What do you then do in respect to treating the latent TB infection to prevent future active TB? Again, you need to exclude active TB. This requires, at a minimum, I think, assuming the resources are available, a normal chest X-ray, a screen for symptoms, and then if either of these are not normal, to collect sputum for culture. Assuming this is done, you then consider both the comorbidity, especially liver disease, and what other medications the patients are taking because of interactions between the treatment for latent TB infection and these medications. And one important one is the oral contraceptive pill, because many of these patients are young and at least half of them will be female. And then finally, you should be conscious of the alcohol intake your patient might have, and because this can increase the risk for liver disease and interact with the medications also. There are a number of different options for treatment of latent TB infection. Traditionally, for some 60 years, isoniazid has been used. And the main reason why this is the mainstay, at least in the past, I think, is that it's been around for the longest. We typically use the standard doses of 10 milligrams per kilogram in children and 300 milligrams in adults. And it can be given with pyridoxine, but I would suggest this is only required, supplementation is only required in patients who are malnourished or at risk of peripheral neuropathy. There's been a lot of debate over the years of how long you should give isoniazid for. In the first statements for treating LTBI in the 1960s, it was given for 12 months. But then trials done initially in Europe in the early 1970s by the International Union Against TB settled on 6 months. And on the right is the graph of the outcome for placebo, 3 months, 6 months, and 12 months. And you can see that there's a substantial better reduction in TB with 6 months, which is slightly less than 12 months, but nearly equivalent. But then subsequently, a reanalysis of this data and other studies in the US by the Public Health Association and a famous paper published by Comstock in 1999 identified that the flexion point in the reduction of cases happens around 9 months. So there was no study of 9 months specifically, but it's for this reason that in the US they recommend 9 months of isoniazid therapy with a slightly better outcome, but a much longer treatment course. The second type of treatment is to give isoniazid with erythromycin, which is the group of drugs that includes rifampicin. And so, for example, in the UK, it's a common practice to treat isoniazid, treat with isoniazid 300 milligrams and rifampicin 10 milligrams per kilogram daily in adults. And the big advantage of this is it's for 3 months, much shorter, but with a higher risk of hepatitis, the main side effect. This has perhaps been supplanted, particularly in the United States, where the standard treatment is isoniazid together with rifapentine rather than rifampicin. And the big difference with this is rifapentine has a very long half-life, and so it allows you to give this medication once per week. So just 12 doses once per week for the 3 months. And this then increases the chance that patients will attend for the medication and have it under direct observation. And so this was shown to be effective in a large randomized controlled trial conducted by a US team, but a global multi-centered trial where they compared this regimen with the 9 months of self-administered isoniazid in a very large group of patients with nearly 10,000 patient years of follow-up. On the right shows in the blue line the difference in the rates, which is very slightly below the level of equivalence. In other words, the two regimens are operating at the same level. So it was shown that this regimen was as effective as 9 months of isoniazid. One of the downfalls of this was there were actually very few active cases in either group, and so the TB incidence was very low. But one of the important outcomes was that the completion of the isoniazid and rifapentine group was far better than the isoniazid alone group, which makes sense given that it's a much shorter and more convenient regimen. And the toxicity profile was similar. And then the final, most recent form of treatment is rifampicin monotherapy, which has become a mainstay in the last 5 to 10 years. This is just giving the standard doses of monotherapy rifampicin, and it makes and this in theoretical terms makes sense because rifampicin in the treatment of active TB is the sterilizing drug, and that's of course what you're trying to do with latent TB infection. This is the large randomized control that followed a trial that followed a number of smaller trials that was led by Dick Menzies out of Vancouver in Canada, but again multi-centered across the US and other places around the world, published in the New England Journal in 2018, that involved a very large number of patients, again, comparing rifampicin 4 months with 9 months of isoniazid. Again, very low numbers of active cases, but it showed that the two a non-inferiority. In other words, the rifampicin was equivalent to 9 months of isoniazid, but with a substantially better completion rate, and in fact, a lot less side effects than the isoniazid, in particular the severe hepatotoxicity. And so this regimen is completed faster than isoniazid, is completed more often, and gives less adverse effects. And so I think is, on balance, generally a better regimen. The issues with rifampicin monotherapy are interactions with other medications, and so some patients won't want to take it because it renders the oral contraceptive pill inactive, or indeed causes problems with the treatment of other illnesses. And it's doubly important that we exclude active TB when we use rifampicin monotherapy, because if you used rifampicin monotherapy with active TB, you will likely induce rifampicin resistance in the active therapy and make treatment of that in the future far worse. And so to conclude, I would recommend for most patients you diagnose latent TB infection using an IGRA, and that you treat it with rifampicin for 4 months, unless it's contraindicated, in which case the 3 months of isoniazid rifapentine, 6 to 9 months of isoniazid monotherapy, or 3 months of isoniazid and rifampicin, probably in that order of priority, are suitable alternatives. Thank you very much.
Hello, this concludes our Day 3 opening plenary on radiology and tuberculosis. I would like to thank our 4 great speakers on sharing their best practices and expertise with us here today. Thank you, and we look forward to seeing you in the next session.